All right, so everybody, welcome. We are very excited to have Dr. Vanna Kirchhoff here, who's joined us on many meetings, and now we're here excited to hear what she has to share with our group. She completed pediatric residency at OHSU in 1999 and has worked in various settings, including general pediatrics, working with an interdisciplinary program for children with behavioral and developmental challenges at Northwest Early Childhood Institute. In 2016, she completed the Andrew Weil Center for Integrative Medicine Fellowship for the same reasons we're here today, because many patients use complementary and alternative treatments, and she felt it was important to be knowledgeable about how to do that. One of her current areas of interest are about using a holistic approach for children with developmental and behavioral challenges. In 2016, with the intention of providing the highest quality of care for her patients, she started her own private practice. And when not practicing medicine, she enjoys spending time with her husband, children, hiking, biking, windsurfing, skiing, and reading good books, all of which sound really nice right now. And with that, I'll pass it over to Dr. Kirchhoff.
Okay, great. Okay, so I'm super excited to talk to you guys today about mast cell activation syndrome as it relates to developmental and behavioral issues in pediatrics. It's been an area of super big interest for me for the past year and a half, but I still kind of feel like I'm just scratching the surface. So if at the end you feel like there's a lot more to learn, I also feel like there's a lot more to learn. So I have a very ambitious agenda. So if it's okay, I'd like to hold questions till the end, just because I'm worried I won't be able to get through it all if I do questions in between. So I've got an ambitious list of learning objectives. I'm hoping to talk both about the impact that mast cell has on pediatric development and behavior, but also on how it can impact physical and mental health across the lifespan. We'll touch on diagnostic criteria, history and physical exam findings, value or lack of value of lab evaluation, triggers to consider, treatment options, and then we'll get some cases, which I'm excited about. I have no conflicts of interest. So what is MCAS? It stands for mast cell activation syndrome, although there's a lot of nomenclature around this issue, so you may hear other people use other terms, but in the literature, mast cell activation syndrome, as defined, is what we're talking about today. It's a condition where mast cells become sensitized and cause problems when they release mediators as a result of being triggered. And it's important to know that mast cells are everywhere in the body. Every organ system has mast cells, and they surround blood vessels and nerves as well. Mast cell activation syndrome is considered a variant of mast cell activation disease. So it's sort of alongside mastocytosis and hereditary alpha-tryptosemia. So it's its own entity, but it's sort of under the umbrella of mast cell activation disease, terminology-wise. And if you use the consensus 2 criteria for diagnosis, which we'll get into here in a minute, about 17% of people qualified for the diagnosis in one German study. So what symptoms can mast cell issues cause? I thought this table was really interesting and helpful, and it really illustrates that almost any organ system can be impacted by mast cells. And I included this table because I wanted to highlight a few things that might pique your interest and not be necessarily in your brain correlated with mast cell before this lecture. So feeling tired, having hot and cold tolerance difficulties, and in particular, poor healing and physical and chemical sensitivities can be challenges. Skin stuff, not just the hives and eczema that we think about, but also alopecia, and some people can respond to mast cell treatment. Keloid formers and people who get stretch marks easily can be more likely to have mast cell disease. Tinnitus can be related, nosebleeds, because heparin is one of the mediators released when a mast cell degranulates. So people with more frequent or more severe nosebleeds than you would expect. Unexpected periodontal or dental disease. Of course, respiratory issues and GI issues, pretty much of all sorts. But also cardiovascular stuff. So not only autonomic instability, but also hypertension, blood pressure lability, palpitations. You can even have angina from an allergic trigger. It's called Cooney's syndrome. There's a lot of GYN stuff that can be related to mast cell issues. So somebody with bad menorrhagia or dysmenorrhea or pelvic pain or vaginal pain, even miscarriages and infertility can be related to mast cell issues. I also want to highlight bone pain. So kids that are having really bad growing pains, that complain of joint pain or bone pain, it's something to think about. And even in older people, osteoporosis or osteopenia can be mast cell related. Neurologic, it's not surprising given all the histamine receptors that are in the CNS that mast cells can be a trigger for headaches, to include migraines, seizures and non-seizure disorders, non-epileptic seizures, dysautonomia, brain fog, sleep issues, and almost any psychiatric issue that you can think of, just again, because the histamine impacts the brain in a myriad of ways. Easy bruising is another one. So somebody that comes in with easy bruising but has normal coags, something to think about. And then people with mast cell tend to have a harder time with more frequent infections, and they have a higher risk actually for autoimmune issues and malignancy. So that's a long list, right, of symptoms to be thinking about. But if somebody comes in with, a cluster of symptoms in different organ systems that's on this list, and there's no other better explanation, it would be something to think about. This is just a table that I included that talks about the impact of histamine in the brain based on several receptors. There's 4. In this study, they looked at 4 different histamine receptors, and you can see that histamine not only impacts, the arousal. So like we know that histamine impacts arousal, right? Because you're sedating antihistamines and non-sedating antihistamines, but it also impacts circadian rhythm, memory, cognition, hunger, thermoregulation, pain perception. It has a lot of impacts depending on which receptor it's binding to. Okay, so how do we diagnose MCAS? There's no true consensus. So there's no like, this is MCAS and this is how you diagnose this, but there are two consensus, two different proposed consensus criteria. There's what's called consensus 1, or maybe self-described consensus criteria, that excludes a lot of people that, in my opinion, would benefit from a trial of treatment for mast cell issues, in my experience, would benefit from treatment. So that's the challenge there. It's a much more limited and stringent criteria. And then there's the consensus 2, which is a newer proposal of diagnostic criteria, which is more inclusive. So let's get into that. The consensus 1 criteria mandates a history consistent with aberrant mast cell mediator release, which makes sense, except for that it's limited to 5 organ systems. And as you saw in the previous slide, we got brain stuff, we got neuro stuff, we've got skin, we've got a bunch of other organ systems that can be impacted by histamine, right? But this one's really limited to skin, GI, cardiovascular, respiratory, and nasoocular. It makes sense that you would have to exclude another disease that could be causing the symptoms. That's reasonable, right? But consensus 1 criteria also requires a rise in tryptase within 4 hours of the flare of a significant amount over an asymptomatic baseline, which is problematic in many ways, not the least of which is that it's hard to get to the lab within 4 hours of the flare. It's hard to establish a baseline. So if you're somebody that's got brain fog and pelvic pain as a result of your mast cell issues, like what's a baseline when you're not in a flare, right? Maybe you're having issues that are chronic and it's hard to find, when are you less and more affected? Or maybe you have different organ systems and you have a migraine, but your pelvic pain's better, right? So there's no published data to support that 20%, as a concrete, reasonable expectation. So it's just really tough to use that as an absolute criteria, which it is in the consensus 1 guidelines. And then also the diagnosis for consensus 1 requires a response documented to mast cell targeted therapy, which is tricky because just like with depression, one person can respond to one mast cell treatment and another person won't and needs a different treatment. So it's kind of like saying you're not depressed if you don't respond to Prozac, right? Which that's a little silly. So consensus 2 requires the major criterion, which is that you've got clinical complaints that are consistent with mast cell issues. And then 1 or more minor criteria, which could be laboratory evidence of mast cell issues, a biopsy that shows greater than 20 per high power field of mast cells, which just, by the way, if you have a patient who's getting an endoscopy and biopsy and you're interested in asking for mast cell staining, you have to specifically ask that they do a stain one of the biopsy samples for CD117 cells. So it's not automatically done. And the threshold is 20 per high power field. And then another minor criteria would be response to mast cell treatment. So you've got one of three options, essentially. The others are more specialty evaluation of mast cell stuff, right? So either you respond to them, you have symptoms consistent with mast cell disease, and either you get better with mast cell treatment, you have blood work that supports mast cell disease, or a biopsy that supports abnormal levels of mast cells. So that's the consensus 2 criteria. And that's really what I'll be talking about today, because I find it to be more helpful. So how is it important, right? So, okay, we've got mast cells. We know they have these impacts on various organ systems. Like, what's the deal then in developmental and behavioral pediatrics? Well, it's special to me because not only does histamine, well, so first of all, mast cells don't just release histamine. They release a ton of stuff, both acutely as a result of degranulation, and then they can actually also constantly secrete some other mediators, and I'll talk about that in just a minute. So they can cause inflammation, they can cause, histamine release and allergic responses, but histamine also acts as a neurotransmitter, and it's important in neurodevelopment. It modulates the immune response and inflammation, and impacts so many things that are important to us in mental health, right? Wakefulness, arousal, appetite, cognition. And then separate of that, histamine and other mast cell mediators can impact physical symptoms that then have an impact on mood and behavior. Whether it's POTS or joint pain or fatigue or eczema or constipation, just that there are multiple physical symptoms that can then impact mood, especially in kids with neurodevelopmental issues. If you haven't pooped, you're not happy if you've got a significant neurodevelopmental issue, right? So that constipation can be huge for mood. So, okay, so what things can trigger MCAS? We all think about, food allergies or environmental allergies or maybe medication allergies. Sidebar, I just had a patient yesterday share with me that her older son, who I don't see, but probably has mast cell just in thinking about the family issues, just was in college and came home terribly depressed for the first time. They had no idea what was going on. And he had some meds for anxiety in the past and had been off them for a year doing fine, and saw his prescriber, and he figured out after the appointment that he had started doxycycline, got terribly depressed, didn't correlate it to the doxycycline until 3-4 months later, went off the doxycycline. Within a couple of days, his depression was completely lifted. So that would be like a potential mast cell mediated neuroinflammatory response to medication, right? So same thing could happen with a dietary or an environmental allergen. Stress can trigger mast cells, either physical or emotional, like a big surgery, car accident, or a big emotional trauma. Hormones, especially estrogen. Excipients are a big one. So those are the extra ingredients in meds or supplements that aren't the active ingredients. And I mention that because people with mast cell will sometimes say, like, I was doing just fine, and then everything went to heck in a handbasket. And a lot of times, especially for people who take multiple supplements, you'll be able to identify a change in the ingredient list of one of their meds or supplements. So they switched from one manufacturer to another of Zoloft, and now all of a sudden their anxiety is out of control. And it may or may not be the quality of the medication. It may be that there's a different excipient list in the new medication. Infections can trigger mast cell, SIBO, mycotoxins, mold. Heavy metals are known to trigger mast cell degranulation. Inflammation in and of itself can trigger mast cells, so kind of a vicious cycle, right? And then chemical exposures. Claudia Miller has done lots of work on chemical sensitivity, and so I really wanted to share with you this website, the Tilt Research website, because it has some amazing resources for clinicians and patients to include screening questionnaires for chemical intolerance. And that's really important for mast cell because mast cell is felt to likely be the mechanism by which people experience chemical intolerance. So a chemical triggers mast cells to be sensitive to that chemical and other things. So it's called a toxicant-induced loss of tolerance. Super interesting sort of sidebar. So, okay, we talked about these hundreds of mediators. And so I wanted to highlight that mast cells can both release mediators through degranulation, where they sort of, explode and release these, little vesicles filled with stuff. And that happens over 15 to 30 minutes, but they can also just synthesize and secrete on an ongoing basis a bunch of inflammatory mediators, which I didn't know actually until recently. So you can see that they can, acutely release heparin. I have a 16-year-old in my practice that when she's stressed just gets profuse nosebleeds. All her coags are negative. but it's insane. And they noticed it first when she got stung by a bee and just got, her parents describe it being like The Exorcist, right? Just horrifying. Um, the and Interestingly, it hasn't happened since she started Prozac. Maybe because stress was the trigger for her. I don't know. Anyway, there's a bunch of different of mediators. There's hundreds more. The point is that mast cells can definitely have significant impacts physically and emotionally. So what do you think about when you're doing a history and exam with regard to MCAS? When there's a child or family history of especially chronic and multi-systemic allergic or inflammatory or dystrophic symptoms, it's something that I start to think about. And it's worth mentioning that for some of these kids, they've had the symptoms for as long as they remember. And so they feel like it's normal to poop every 4 days, or to always have stomach pain after you eat, or to not be able to sleep. It's just interesting what people will feel is normal because they've never experienced anything else. So asking the specific questions. Pregnancy wise, asking about mom's allergies, either, coming on or resolving during pregnancy. Having significant morning sickness can be an MCAS thing. Pups, and then of course trauma or significant stress during the pregnancy can be related to mast cell issues for the child of that pregnancy. With regard to additional infancy history, there's often a history of difficulty tolerating formula, or mom having to limit her diet to successfully breastfeed, trouble with solids, super fussy / super colicky baby. And then this is I knew where the intersection with pandas is really interesting. If there's a persistent acute change in mood and behavior after any kind of stressor, that could be a mast cell thing. So I start to wonder how often is mast cell the foundational issue when somebody meets criteria for pandas and pans, right? That's a wonder that I have, and I don't, it's been an interesting thing to think about. There have been papers published on the intersection, but I don't think it's been fully explored. And then of course, any developmental or behavioral challenge, because we know that mast cells impact the brain and can impact neurodevelopment and be neurotransmitters. So we kind of talked about all this, but this is a list of the things that you would ask about or look for. Highlighting again that, being tired all the time, having bone or joint pain, unexpected levels of dental disease, nosebleeds, abnormal healing, cardiovascular stuff, GI stuff, especially gastroparesis, by the way, things people just can't move things through or have a sense that their food doesn't go down. That's been something that I've found to be more common in the mast cell population. I know we talked about the more frequent infections and immune issues, and the GYN issues already. I want to highlight the triad of dysautonomia and hypermobility and MCAS because there's a Venn diagram I'll show you here in a minute. There's a big overlap. So if you have one, it's really important to screen for the other. So if you have a patient with Ehlers-Danlos, or they're just bendy, because there's a lot of people who meet all the criteria for Ehlers-Danlos except for the first degree relative. So if you're just really bendy, or you have POTS or any other dysautonomia, the possibility you have MCAS goes up significantly. And then of course, kids who have a history of worsened symptoms of any kind with exposure to dyes or preservatives or chemicals, especially VOCs, herbicides, and pesticides. But certainly fragrances and everything else as well. So this is the triad Venn diagram that I was talking about, where you see the overlap in the symptoms of this. They say hypermobile Ehlers-Danlos, but I would say hypermobility. POTS, and I would actually translate that to dysautonomia as a broader term, and then MCAS. And then some people talk about pentad or even septad. Pentad adds GI dysfunction and autoimmunity to that Venn diagram. Okay, so I got to thinking when I was learning about MCAS, whether there were some people that were responding to their meds because they were antihistamines and not because of their intended purpose. And so 2 categories of meds that made me go, were tricyclics, because, for example, doxepin is 800 times stronger than antihistamine, than diphenhydramine, and amitriptyline is 4 times less strong than doxepin, which I guess makes it about 200 times stronger than diphenhydramine. So the people that are taking amitriptyline for their IBD and get so much better, maybe it's a mast cell issue, right? And maybe their anxiety and depression that gets better at the same time was also a mast cell issue. Um, H2 blockers, and I don't have too many kids on amitriptyline in my practice, but I certainly have parents who will say, "Oh yeah, amitriptyline is the only thing that ever worked for my, you name it." H2 blockers too. So if somebody gets an H2 blocker for reflux and all of a sudden, other systems are working much better, that's indicative potentially of a mast cell etiology for those other symptoms. And then our second generation antipsychotics are antihistaminergic, or antihistaminic, or I don't know, actually, I should probably know that word as somebody talking about mast cell, but they're antihistamines too. It's worth noting that having something be a stronger antihistamine does not make it more likely to be effective in treating MCAS. So the strength of the antihistamine property is not correlated with efficacy, strangely, or maybe not strangely. Okay, so now you've listened to me and you're thinking like, I have this patient, I think they might have MCAS, what do I do? Or if the 17% criteria is right, 17% of you are thinking, I might have MCAS, what do I do? Right? So let's talk about labs. Labs are tricky because in patients who have clearly got MCAS, maybe they've had a positive biopsy, maybe they've responded dramatically to MCAS therapy, their labs aren't always positive. And that could be because histamine is rapidly metabolized, and most of the tests that we do are assessing histamine and histamine metabolites. So maybe they're not at that moment having elevated histamine when the labs are drawn. And it's probably also because the procedures to get an accurate test are quite involved and require refrigeration of the sample literally from the time it's drawn. It has to be drawn into a cold tube, has to be kept refrigerated, has to be centrifuged refrigerated, and there's a lot of opportunities along the way for the specimen to be mishandled and then have a lower value, because at room temperature histamine degrades really quickly, than would be helpful. So the one thing that's at least on my lab order panel that does not require refrigeration or special treatment is serum chromogranin A. It's pretty cheap, like $50, and it's relatively high yield compared to other options. But you can't be on a proton pump inhibitor if you're going to do serum chromogranin A for at least 3 weeks. All the other specimens need to be chilled like immediately, so it's kind of a pain. And then heparin is additionally kind of a pain, because if you're not taking heparin, you shouldn't have a heparin level of greater than 0.02. But most labs don't test below 0.1. So if your lab says, oh, you're less than 0.1, and actually your level was 0.08, and you're not taking heparin, you actually have a higher level of heparin than you should for somebody not taking heparin. The heparin, histamine, and chromogranin A are relatively inexpensive, like $40 to $80. All of the others on the list, the PGD2, urine and serum, and the other urine tests that I have listed here are more expensive. And by that, I mean like $400 to $700. So for a patient who potentially is going to be paying out of pocket for labs, that's really important, or might not have insurance coverage for labs. Another tricky part, all anti-inflammatory meds, supplements, everything has to be avoided for a week prior to the draw. It's okay to have vitamin C, D, and E in food, but not supplemental. So no multivitamins, no Motrin, no Advil, no anything. But they can continue antihistamines and H2 blockers, interestingly. And that's important to tell them, because I've had a couple of patients be told by the lab that they wouldn't draw specific parts of the order because they were taking antihistamines, which is totally not appropriate. I give the parents a copy of the lab order. I'll show you my lab order here in just a minute, and have them make sure that the person doing the draw has read the special instructions. So they actually take 2 copies to the lab, one to give to the person checking them in just to make sure that everything's correct on the order, and one to give the actual phlebotomist to say, hey, I just want to make sure that these instructions got put on, your paperwork, because they're specific instructions about refrigeration and how to draw it into the cold tube and blah, blah, blah. So we just want to make sure that that happens. And then I always recommend parents have labs drawn in a major hospital if they can, so that we don't have transport from the outlying thing to further complicate the refrigeration issue. So I've revised this a million times, because every time I have a problem, I just revise my lab order. But you'll note that I have where to send it, the test codes, the special instruction. For my own reference, I bolded the higher yield labs just based on a paper that talked about, which labs were more likely to be positive. And then I'm getting better and better results over time. Now I just added the important part, the paragraph on the top, for patients to reference, that's part of the lab order, and I just circle it when I give it to them, so it's with the lab order that they're taking in. Okay, so okay, now you have a patient with symptoms, or you yourself have symptoms. You have labs that are positive or negative. What's next? So I recommend a 2-week period where patients avoid the known triggers, and you'll be surprised how many people are like, yeah, I know I react to gluten, but I ate it anyway, or yeah, I know that, whatever's not good for me, but I don't really avoid it. So I asked them to avoid known triggers. I asked them to do a whole foods diet with no dyes or preservatives for 2 weeks. If they want to go off other things, gluten, dairy, whatever, they can, but they don't have to during this time frame. And then ideally they minimize use of chemicals. I mean, ideally they eliminate use of chemicals, like specifically fragrances and anything they're spraying around the house, fabric softeners, cleaning products, that kind of thing. We all know that that's really hard to eliminate for most households, but I make them aware of it and ask them to eliminate as much as possible. And then if there is concern for mold exposure where that child is living, we talk about whether we could maybe stay with grandparents or stay somewhere where there's not felt to be a mold exposure for that 2-week period. And not everybody can do all these things, right? So we do as much as we can of this list. And then if things are dramatically improved at the end of that 2-week period, then we try and figure out, okay, what's the trigger and can we avoid it? So I would say 10% of my patients can achieve this, ideal agenda. But if they're really motivated or there's an opportunity, oh yeah, we're going to our, our beach house for 2 weeks and we could totally do a whole foods diet there and minimize, we'll just do it during that time frame. That can be great. After that, the standard end quote procedure, there's no treatment protocol, but many people that treat mast cell will try 2-week trials of each over-the-counter antihistamine, starting with the non-sedating. Benadryl is really too short acting to use for this trial. And I have people track their symptoms. Okay, so for each day, I want you to rate your top 5 problems on a level of, 1 to whatever, just at night before you go to bed. And that's because week 5 or 10, it's really hard to remember how things were week 1 if you're going to do a 2-week trial of each of the 5 major over-the-counter antihistamines. And then if that doesn't work, you can try a prescription sedating antihistamine, which honestly, the reason that they're sedating is they get into the brain. So if you're trying to get a brain problem under control that you think is mast cell derived, then you may have more success with cyproheptadine or hydroxyzine or cromolyn. Cromolyn actually it seems like is more effective for gut issues. So if somebody has pretty extreme gut issues and other issues that you're treating, the cromolyn's may be more likely than some of the other H1 and H2 blockers to impact gut function. So like, gastroparesis or abdominal pain after eating or, IBS, you might have a lower threshold to try cromolyn. Specifically, the people who do this a lot tell me that the liquid form of cromolyn is better. And cromolyn's kind of a pain because it's dosed usually TID. So that anything TID is difficult, but if it gives you great relief and allows you to eat, then that can be worth it to just have it right before a meal. Usually people recommend finding the best H1 blocker and then adding an H2 blocker. Obviously, if you've got big GI stuff, you could start with the H2 and then add the H1. Famotidine has the least drug interactions with at least the drugs that I prescribe. And then ranitidine, is back on the market. Cimetidine has the most drug interactions, so need to be more careful with prescribing that as far as the H2 blockers go. And then from a traditional medical perspective, adding zinc, vitamin C, vitamin D, B vitamins, and magnesium is a next step. But for me, it's a first step because pretty much everybody that I'm going down this pathway, I've already optimized zinc, vitamin C, vitamin D, B vitamins, and magnesium. That's kind of a first step for me. But also, I would love to talk about flavonoids. So there's actually a ton of literature about the mast cell stabilizing benefits of quercetin and luteolin. Um, Interestingly, how a liposomal form is more effective, especially for neuro complaints. And one of the lead researchers in the mast cell literature, lead publishers and researchers in the mast cell literature, and I'll get to his research here in a minute, developed liposomal formulations and has published studies on their use in kids with autism that are very cool. And I'll give you his website and some of that information in a minute, but those liposomal formulations are available at his company, which I think I can talk about companies, right? Because we're not seeming good. Okay, which is Algonaut. Algonaut.com is the place where you can get these different mixtures and formulations. It's pretty cool, and the research is pretty cool around it. Anything that reduces stress is going to help with mast cell stabilization, right? Acupuncture, meditation. I'm not sure what the published literature is about limbic system retraining programs, but people who are really impaired with mast cell stuff have done them with good, people have reported that's been of benefit. So people who do a lot of this work will use this sort of as almost as a last resort because they're expensive and extremely time consuming. But if someone's really impaired and not able to do anything, it could be an option. And then as I was doing some research, I found that L-theanine can have some mast cell stabilizing properties, which is kind of awesome because we use it for anxiety and ADHD. And there's a lot of other supplements that stabilize mast cells. I mean, the list is huge. I mean, I could just, like slides and slides. But it's, if you think somebody's got a mast cell issue and you're wondering about a specific supplement, it's reasonable to look it up and be like, hey, I wonder if ashwagandha stabilizes mast cells, right? Like that could be an interesting thing to evaluate. Okay, so I think I'm okay. Oh gosh. I wanted to mention a few patients that made me curious in my practice. And I'll sort of summarize this list versus go in detail for each one because I want to spend some time on the next slides that I think are really impactful. I've seen unexpected developmental catch-up / progression, adding cyproheptadine to for appetite stimulation, in a family where the dad had a severe IBS case that responded to amitriptyline. And the kid, although he didn't have any allergy symptoms, had a bunch of stuff come up on IgE testing. I've had a couple of kids have dramatic decreases in their anxiety with Zyrtec. I had another kid who I added zinc to help with anxiety, and it completely resolved her seizures, for which were so bad she was on double or triple therapy, max anticonvulsant therapy, and she was scheduled for VNS, which they then canceled because adding the zinc took care of her seizures. Later, that same mom added B6 at a high dose, 100 milligrams, which I would have never recommended. She just did it on her own and reported dramatic improvements. And both zinc and B6 can stabilize mast cells. That same girl had a biopsy on her endoscopy, and I asked for the CD11 staining, and she had elevations. Every biopsy was elevated over 20. But her labs were negative. However, she didn't have very many labs because they told her they wouldn't draw them because she was taking an antihistamine. I just had a few off the list. I had another kid with a huge behavioral improvement with cyproheptadine. He has a history of PANDAS, onset at 1 year of age when he had periorbital cellulitis, and now has diagnoses of ADHD, anxiety, PANDAS, Tourette's, autism. Family did not actually, we put the cyproheptadine on board because he had some appetite suppression with his stimulant, but really needed that support, and we couldn't find any other way to do it. And we thought it was other things that were helping him, or maybe just that he wasn't getting hungry, but then they pulled the cyproheptadine while they were on vacation because they were concerned about photosensitivity, and everything went to heck in a handbasket. And when he started the cyproheptadine again, it was great. That same child is doing better with luteolin that I just added recently. It's been significantly beneficial for him. I had a kid who destroyed my waiting room after eating seafood. That was totally fine. Otherwise, they figured out later that it was a seafood allergy. I had another kid whose OCD came and went based on dairy intake. And I had another kid whose flapping resolved and engagement got much better when they started a whole foods diet. And it was pretty dramatic because his lunch was a Hot Pocket, Cheetos, and Twinkie every day. And I was like, I didn't even know they still had Twinkies. I was like, they still sell that, right? So they went to a whole foods diet, and then everything came back. They called me in a panic because everything came back, and it turned out they gave him blue Gatorade for his stomach flu. and then everything came back. Okay, so this is the case series I really wanted to share with you. It just came out like days ago, maybe within the past month, about 8 people with pretty severe psychiatric issues that had pretty dramatic, they're all adults, pretty dramatic response to MCAS directed therapy. Okay, so we've got one person with bipolar, 5 with generalized anxiety, 4 with was it panic? Sorry, I can't see that part of my slide. You can see the second bullet. And there were additional diagnoses: ADHD, OCD, Tourette's, narcolepsy. And then I really want to highlight that these 8 people all met criteria for MCAS. That's why they were in the study. 4 had POTS. Another 4 had cardiac issues, 2 had migraines, 2 had restless legs, and 4 had hypermobile joints, hypermobile Ehlers-Danlos. And that's that triad that I'm talking about, right? So with just mast cell directed therapy, which I'll talk about in a minute, 6 of them returned to work, school, or college. 1 went back to functioning perfectly as a homemaker, and 1 who was bedridden 4 days a week started working part-time. That's pretty impressive, right, for our patient population. It's worth noting there's no FDA approved treatment protocol, but the meds are FDA approved, right, for allergies, but not FDA treatment protocol. Okay, so they, unlike my treatment recommendations, they advise 3 weeks on a gluten and dairy free and low histamine diet. And I will say that in the mast cell community, that's pretty common. It's hard in my patient population to have kids that have neurodevelopmental differences go all of a sudden gluten and dairy free and low histamine. It's just almost impossible. So I opt for the whole foods option. But I think this would be really reasonable for an adult population, especially a really motivated adult population. They added an H1, H2 blocker twice a day. And then if they were still having troubles, they added vitamin C, D, and quercetin. And then they added LDN. And then if the LDN still didn't do it, they added other things that are more advanced and beyond the scope of this talk. So is this not so cool? So the first 4 patients are in the column. So it talks, patient 1 obviously is the first column, then 2, then 3. And I would just bring your attention to not only the symptoms that they had, which makes sense with regard to what we talked about could be comorbid, but sort of highlight the importance of paying attention to things like, oh, you also, in addition to your bipolar disorder, you also have abdominal pain, nausea, bone pain, hallucinations, you are bedridden. That's not just from your bipolar, right? Look at everything she tried. This is the least robust response, but she went from bedridden 4 days a week to working part-time. That's pretty amazing. Her comorbid stuff was POTS, restless legs, and labile hypertension. So that's the least amazing response, right? We have somebody else who had generalized anxiety disorder and panic and needed a pacemaker for her bradycardia, anxiety, joint pain, syncope, pre-syncope, and had a complete response. Works full time. Her tachycardia, syncope, flushing, and anxiety resolved just with adding MCAS therapy. And it's just an H1 and H2 blocker for her, right? This one had, rashes, facial swelling, itchy, syncope, tachycardia, migraines, postpartum phobias, tried multiple SSRIs, was diagnosed with hypermobility. I forgot what NCT stands for, but it's down there. I think it's on, NCS, non-cardiogenic syncope, is that right? I'll move on. And inappropriate sinus tachycardia. She had a complete response, and that's to her neuropsychiatric difficulties, right? Works full time, just with hydroxyzine and cetirizine and as needed prednisone for flares. So amazing. The person in the last column is perhaps the most impressive. So this is somebody who had daily suicidal ideation, a history of headaches, hives, allergies, nausea, abdominal pain, depression, menorrhagia, tinnitus, chest and body pain, interstitial cystitis, which is a very common diagnosis for people with mast cells, has tried a bunch of stuff, got diagnosed with POTS in addition to MCAS. Hydroxyurea is something that we would add after LDN. I've never prescribed hydroxyurea, so this would be like a more advanced thing to add on. Complete response, depression resolved, independent and everything, right? Like, that's kind of crazy. And here's some other, I want to leave time for questions. Here's some other ones. It's so amazing to me that when you look at these comorbid symptoms, right? And then you look at how little had to be done. And these guys all had LDN added, but a low dose naltrexone with a non-sedating antihistamine and some cimetidine, and they've had complete resolution of all their psychiatric symptoms. I think that's kind of amazing. So I want to give special thanks to Dr. Larry Afrin, who not only has been kind of a leader in the mast cell community, the online community, and with regard to publishing both books and literature, but also was kind enough to review my presentation and give me incredibly valuable feedback on it. Dr. Tanya Dempsey, who works with Dr. Afrin, also has been very generous with her time and talking with me about my questions about mast cell. And then I mentioned somebody who had done the research on the flavonoids and sold the products on Algonaut, and that's Dr. Theo Hardy's, who was one of the first to recognize the clinical importance of mast cell activity in the brain. And that's his website that has mastcellmaster.com, has amazing research and clinical information on it if you're interested in looking into it more. And then I am part of a pretty fabulous international community of practitioners interested in mast cell activation syndrome. And I am happy to recommend anybody who's interested for membership. It's just free. It's an email discussion group, and people are so generous with their time and expertise. When newbies or people with great expertise post difficult patients, it's really fantastic. There's another beautiful picture of a mast cell, and that's my email. If you're interested in more information, or if you want to be nominated to be part of the mast cell group and have, I don't know, 10 to 20 emails in your inbox every day from them, just saying.